this is the most important video within this series because finally now you are going to learn the actual concept of jaundice and then the three types of jaundice: pre-hepatic, hepatic, and post-hepatic jaundice. And finally, very important, liver function tests that will allow you to distinguish between pre-hepatic, hepatic, and post-hepatic jaundice. So first things first, what is the difference between hyperbilirubinemia, jaundice, and icterus? See, within your blood, the total bilirubin level normally is 0.3 milligram per deciliter to 1.2 milligram per deciliter. So this is the normal range of total bilirubin in your serum or blood. This is the normal range, that is 0.3 milligram per deciliter to 1.2 milligram per deciliter. When the serum total bilirubin level becomes greater than the normal upper limit, that is greater than 1.2 milligram per deciliter, then that condition is referred to as hyperbilirubinemia. Hyper, excess, bilirubin, bilirubinemia in blood, the presence of excess bilirubin in blood, the presence of bilirubin beyond the normal upper limit. That is, even if it is 1.3 milligram per deciliter, it is still greater than the upper normal limit. This is hyperbilirubinemia. But just because a patient has hyperbilirubinemia doesn't mean he also has jaundice. So what is jaundice? See, the level of bilirubin is greater than the upper limit, 1.3 milligram per deciliter, greater than 1.2 milligram per deciliter. So the patient has hyperbilirubinemia. Now, let's say the pathological defect causing hyperbilirubinemia in that patient is not being taken care of. As a result, the bilirubin level keeps on rising, 1.3 milligram per deciliter, then 1.4 milligram per deciliter, then 1.5 milligram per deciliter, then 1.6 milligram per deciliter, then 1.7 milligram per deciliter, then 1.8 milligram per deciliter, then 1.9 milligram per deciliter, and around 2 to 2.5 milligram per deciliter. At around this point of hyperbilirubinemia, physical, clinical manifestations are appreciable by naked eye. At this point, when such clinical features are well appreciated by naked eye, what kind of manifestation? So when bilirubin is at around 2 to 2.5 milligram per deciliter within the blood, this high level of bilirubin, significant level of bilirubin, they go and deposit at certain parts of your body like skin, sclera, the white part of your eye, mucosa, and the interstitial fluid. Leading in, bilirubin itself is yellow in color. So if they go and deposit in skin, sclera, mucosa, and interstitial fluid, it is going to turn those parts yellow as well, leading in yellow discoloration. And this yellow discoloration is finally referred to as jaundice. So just because there is increased level of bilirubin, it doesn't mean the person has jaundice. It simply means there is hyperbilirubinemia. But when hyperbilirubinemia is significant, that is around at least 2 to 2.5 milligram per deciliter, then there is so much hyperbilirubinemia that bilirubin go and deposit in skin, in sclera, in mucosa, in interstitial fluid, turning them into its own color, that is yellow. Now this is called jaundice. So finally, the definition. First, hyperbilirubinemia, when the level of total serum bilirubin is greater than the upper normal limit, greater than 1.2 milligram per deciliter, we refer to it as hyperbilirubinemia. But the yellow discoloration of skin, mucosa, sclera, and interstitial fluid due to significant hyperbilirubinemia of at least around 2 to 2.5 milligram per deciliter is referred to as jaundice. So a very important statement here. Not all hyperbilirubinemia leads to jaundice. See, when bilirubin, total serum bilirubin level is 1.3 milligram per deciliter, At this point, the person has hyperbilirubinemia, but the person does not have jaundice. So not all hyperbilirubinemia leads to jaundice, but all jaundice is due to significant hyperbilirubinemia. So the person has jaundice at this point, right? That is, there is yellow discoloration of skin, mucosa, sclera, and interstitial fluid. This is due to significant hyperbilirubinemia of at least around 2 to 2.5 milligram per deciliter. So there is increase in bilirubin, yellow discoloration is not seen, increase in bilirubin, yellow discoloration is not seen. There is hyperbilirubinemia, but yellow discoloration is not seen. There is hyperbilirubinemia, but yellow discoloration is not seen. And then at a significant level of hyperbilirubinemia of around 2 to 2.5 milligram per deciliter, finally yellow discoloration is appreciated, and this is called jaundice. That means not all hyperbilirubinemia leads to jaundice, but when there is jaundice, it is due to significant hyperbilirubinemia, at least of 2 to 2.5 milligram per deciliter of total bilirubin in blood serum. I can't make the concept clearer than this. Okay, now see, I said there is deposition of bilirubin in jaundice in skin, in sclera, in mucosa, and then interstitial fluid. But I have written the sclera in yellow. Why? Because the yellow discoloration of just the sclera, I repeat, the yellow discoloration of just the sclera due to significant hyperbilirubinemia is referred to as icterus. So see, the total yellow discoloration of skin, sclera, mucosa, interstitial fluid due to significant hyperbilirubinemia is your full-blown jaundice. Okay, that's your jaundice. But when you are referring to just the sclera, the yellow discoloration of the sclera, also due to the same significant hyperbilirubinemia, that is icterus. Okay. Now, first question, why yellow discoloration? If you know your heme metabolism, you must know that heme is red in color. When heme gets broken down into biliverdin is green in color. Then biliverdin gets reduced to bilirubin, and bilirubin is yellow in color. So if bilirubin goes and deposits somewhere, it is going to impart yellow coloration to that somewhere. Simple. So it goes and deposits where? In the skin. It goes and deposits to sclera and interstitial fluid. It goes and deposits in mucosa, turning them yellow in color. Okay. So, okay, it goes and deposits in skin, sclera, mucosa, interstitial fluid. Why did people decide to give the yellow discoloration of just the sclera a special name of icterus? Why is it so special? This is the reason why it is special. See, when jaundice is about to happen, right? So the level of bilirubin is greater than the upper normal limit of 1.2 milligram per deciliter. That is hyperbilirubinemia. Then bilirubin level rises, leads to significant total bilirubin, significant hyperbilirubinemia of around 2 to 2.5 milligram per deciliter. At this point, bilirubin goes and deposits at various parts of the body, leading to its yellow discoloration. Right. Now, the reason the yellow discoloration of sclera has been given special name is because this yellow discoloration of sclera is manifested very fast. Okay, that is the very first physical sign that is seen. That is, even before bilirubin deposits in skin or mucosa or interstitial fluid, it first goes and deposits in the sclera. So there can be a person with yellow discoloration of sclera but no yellow discoloration of skin yet occurred. It will occur later on, but first it's the sclera that has gone yellow. The skin is yet to become yellow, mucosa is yet to become yellow. That is, if bilirubin level keeps on rising further, the bilirubin will go and deposit in skin. See, first bilirubin goes and deposits in sclera. So first yellow discoloration of sclera is seen, and this yellow discoloration of sclera due to significant hyperbilirubinemia is icterus. So icterus is the first physical sign of jaundice. Later on, when bilirubin level rises even more, it goes and deposits in other parts like mucosa, skin, and interstitial fluid. So since yellow discoloration of sclera is seen first, it is given a special name of icterus. So if a patient with hyperbilirubinemia comes to you, and this patient has physical sign of icterus, physical sign of yellow discoloration of sclera, that means this patient is soon going to develop full-blown jaundice, that is yellow discoloration of skin, mucosa, interstitium is going to appear soon after icterus. That's why it's clinically important. Another question: why is it that yellow discoloration of sclera is seen before skin, mucosa, and interstitial fluid? Or let's say before skin and mucosa. Why before skin and mucosa? Three major reasons. Number one, sclera is white in color. So when bilirubin goes and deposits there, imparting yellow color, it is quite contrasting over the white background. White background, yellow discoloration, visible quite easily appreciable by naked eye. Number two, sclera has high vascularity, so more bilirubin can go there. Number three, high elastin. See, bilirubin, why is it going and depositing in skin, mucosa, sclera? Why? Because these structures, they contain high amount of elastic fibrous connective tissue, and bilirubin loves elastic fibrous connective tissue. And out of all these three, your sclera has highest amount of elastic fibrous connective tissue. So bilirubin loves elastic fibrous connective tissue. In sclera, it is going to find lots of elastic fibrous connective tissue, and it is going to go and deposit there. Okay, that's it. Now finally, the types of jaundice. Let's see. Aita, jaundice, which is the yellow discoloration of skin, sclera, mucosa, and interstitial fluid as a result of significant hyperbilirubinemia of at least around 2 to 2.5 milligram per deciliter. It is of three types, depending on the pathological defect occurring either before liver, within liver, or after liver. If you know your heme metabolism, this is going to be really easy. And yes, I've already explained heme metabolism in detail, but even if you don't know it, no worries. I'll explain it here itself. Very short, only the significant point you require to know the types of jaundice. See, so there is your liver. There is activities taking place before liver and activity taking place after liver. Before liver, during heme metabolism, what happens? The red blood cell, it gets broken down. The hemoglobin gets broken down. The heme gets broken down, and the heme is converted to unconjugated bilirubin, which is lipid soluble but bound to albumin. The process which allows this to occur is referred to as hemolysis. The breakdown of hemoglobin to unconjugated bilirubin is hemolysis. After hemolysis, the unconjugated bilirubin present within your blood is carried to your liver by albumin. So unconjugated bilirubin is first uptaken by the liver cell. Then the process of conjugation takes place, which converts unconjugated bilirubin to conjugated bilirubin. Conjugated bilirubin is water soluble and excretable. The process that allows this conversion is conjugation. So conjugation takes place. After that, conjugated bilirubin from the hepatocyte is secreted into biliary canaliculi. Biliary canaliculi. The biliary canaliculi, as you must know from your general anatomy, not the general anatomy, but the anatomy of gastrointestinal tract, it opens into second part of the duodenum. So the conjugated bilirubin is secreted into biliary canaliculi. From there, through the biliary duct, the bile duct, it enters the second part of the duodenum. This is your bile flow. So conjugated bilirubin enters the duodenum along with the bile. The bile contains bile salt and acid. and the thing that makes bile salt and acid, that is cholesterol, and this conjugated bilirubin. Okay, so if pathological defect occurs before liver in the process of hemolysis, it leads to pre-hepatic jaundice. If pathology or defect occurs within the liver, then that is hepatic jaundice. If pathology occurs after the liver in bile flow, then that is post leading to jaundice, then that is post-hepatic jaundice. Simple. So first you have pre-hepatic jaundice. Pre-hepatic jaundice, where the pathology is before the liver in the process of hemolysis. See, so first RBC containing hemoglobin with heme is broken down by the process of hemolysis into unconjugated bilirubin. If there is excessive hemolysis, too much hemolysis, either in adult or in infant, there is excess hemolysis, this will result in production of excess unconjugated bilirubin, and that will lead to unconjugated hyperbilirubinemia. So this jaundice, pre-hepatic jaundice, is associated with unconjugated hyperbilirubinemia, and the reason behind it is excessive hemolysis. Since the cause is excessive hemolysis, it is also referred to as hemolytic jaundice. Simple as that. Again, since the cause resulting in the jaundice is before the liver, it is pre-hepatic jaundice. Since the cause is excess hemolysis resulting in breakdown of huge amount of hemoglobin to huge amount of unconjugated bilirubin, the jaundice is also referred to as hemolytic jaundice. Since there is excess breakdown of hemoglobin into unconjugated bilirubin, the jaundice is associated with unconjugated hyperbilirubinemia. Second is due to defect within the liver. So it is referred to as hepatic jaundice. Hepatic jaundice. What happens is the cell of the liver or the hepatocyte somehow gets injured, referred to as hepatocellular injury. Now this injury is most commonly due to hepatitis, like viral hepatitis, or it could also be due to liver cirrhosis. Be it hepatitis or liver cirrhosis, at the end of the day, there is hepatocellular injury. And when there is hepatocellular injury, two things happen. Number one, the cell of the liver loses its function. As a result, conjugation does not happen, resulting in elevated level of unconjugated bilirubin, resulting in unconjugated hyperbilirubinemia. But there is second thing that happens. That is, the cell, the hepatocyte, it inflames or grows larger in size. Hepatitis, there is inflammation. The cell grows larger in size. It swells up, right? Due to swelling up of the cell, the biliary canaliculi gets compressed. The adjacent biliary canaliculi to the cell gets compressed. So whatever conjugated bilirubin is there has nowhere to escape, because the escape door is closed, the biliary canaliculi. The adjacent hepatocytes, they grow larger in size and they press on one another, closing the biliary canaliculi, press on one another, closing the biliary canaliculi. As a result, the conjugated bilirubin has nowhere to escape. So where does it go? It goes back into the blood circulation, resulting in conjugated hyperbilirubinemia as well. So in hepatic jaundice, both unconjugated and conjugated hyperbilirubinemia is seen, and the cause behind it is hepatocellular injury due to hepatitis or cirrhosis. So it is also referred to as hepatocellular jaundice. That's why it's also referred to as hepatocellular jaundice. All right. The third type of jaundice, that is after, due to pathology after the liver. So referred to as post-hepatic jaundice. Post-hepatic jaundice. After a liver, what is there? See, within the liver, conjugation takes place. Unconjugated bilirubin is converted to conjugated bilirubin. Now this conjugated bilirubin is spelled out into the duodenum along with bile. So it passes through the biliary system. Bro, there's your liver, there's the there's your left hepatic duct, the right hepatic duct that combine to form the common hepatic duct that meet with the cystic duct, resulting in the formation of common bile duct that meets the pancreatic duct, forming the hepatopancreatic duct that leads to ampulla of bladder that opens into second part of duodenum via sphincter of Oddi. You know that, right? So bile comes through all these ducts and enter the second part of duodenum. Along with the bile comes conjugated bilirubin as well. But within this bile flow, if obstruction occurs anywhere within the liver or outside the liver, obstruction occurs, what will happen? Conjugated bilirubin will be accumulated within the hepatocyte. It won't get into the duodenum. Now the escape door is closed due to obstruction. So all this conjugated bilirubin will be expelled back into the circulation, resulting in conjugated hyperbilirubinemia. The reason behind it is obstruction of the bile flow. Obstruction of the bile flow, also referred to as cholestasis. Cholestasis. That's why we call it obstructive jaundice as well. That's it. So there's 3 types of jaundice. If it is due to pathological defect occurring before the liver, it's prehepatic jaundice. If it is due to pathological defect occurring within the liver, it is hepatic jaundice. And if it is due to pathological defect occurring after the liver, then that's post-hepatic jaundice. Before liver, the pathological defect that occurs is excessive hemolysis. So the jaundice due to excessive hemolysis is also referred to as hemolytic jaundice. Within the liver, the pathological defect that occurs is hepatocellular damage, either due to hepatitis like viral hepatitis or liver cirrhosis. So jaundice due to hepatocellular damage is referred to as hepatocellular jaundice. After the liver, the pathological defect that leads to jaundice is obstruction in the bile flow, which is also referred to as cholestasis. So the jaundice is also referred to as obstructive jaundice. In hemolytic jaundice, since there is massive destruction of hemoglobin, converting it into unconjugated bilirubin, it is associated with unconjugated hyperbilirubinemia. Since in hepatic jaundice or hepatocellular jaundice, there is hepatitis inflammation of the cell leading to loss in function of the cell, resulting in increase in unconjugated bilirubin, but at the same time swelling of the cell that compress over one another and completely obliterate the bile canaliculi, sorting off the escape door for conjugated bilirubin, resulting in increment in conjugated bilirubin. So it is associated with both unconjugated hyperbilirubinemia and conjugated hyperbilirubinemia. In post-hepatic jaundice, since there is bile flow obstruction, conjugated bilirubin can't enter the duodenum. Along with conjugated bilirubin, the content of the bile, that is bile salt and acid and cholesterol, they don't enter the duodenum, so they get pushed back into the circulation, resulting in conjugated hyperbilirubinemia as well as increase in level of bile salt and acid and cholesterol in the blood. That's it for the types of jaundice. Now, very important topic that you need to know, and that is the liver function tests that will help you distinguish in between prehepatic, hepatic, and post-hepatic jaundice. Let's see. Beginning off with prehepatic jaundice, which is also referred to as hemolytic jaundice. It is referred to as hemolytic jaundice because the defect occurs within hemolysis. There is excessive hemolysis. Due to excessive hemolysis, there is excess breakdown of hemoglobin, resulting in increase in unconjugated bilirubin. See, when there is excess hemoglobin, there is excess hemolysis, there is excess breakdown of hemoglobin and excess production of unconjugated bilirubin. Okay. So first, bilirubin level. Total serum bilirubin. There is a rise in total serum bilirubin. Serum unconjugated bilirubin. there is rise in serum unconjugated bilirubin. Serum conjugated bilirubin. Serum conjugated bilirubin remains normal. Why? Because there is no problem with the cell, hepatocyte. So conjugation taking place is normal. So normal amount of conjugated bilirubin is being produced. Second, there is no problem with the bile flow. So whatever conjugated bilirubin is being made, it has a way to enter the duodenum. So there is normal level of conjugated bilirubin in blood serum. As for unconjugated bilirubin, it is elevated due to excess hemolysis. Okay. Now see, there is excess breakdown of hemoglobin. There is excess hemolysis resulting in excess production of unconjugated bilirubin. So there is excess unconjugated bilirubin in blood. This excess unconjugated bilirubin reaches the liver. So there is excess uptake. This excess unconjugated bilirubin goes through the process of conjugation. So there is maximum conjugation by the liver taking place. Maximum conjugation. Maximum potential of the liver to conjugate is taking place because there is excess unconjugated bilirubin. So liver is trying its best to conjugate as much unconjugated bilirubin as possible. As a result, there is also increment in conjugated bilirubin, but there is increment in conjugated bilirubin inside the hepatocyte, not in blood. That is why in blood, the serum conjugated bilirubin remains normal. It's in the hepatocyte where conjugated bilirubin is high. And fortunately, the bile flow is normal. So all this conjugated bilirubin, it will enter inside the duodenum. Now there is excess conjugated bilirubin, high conjugated bilirubin in the duodenum. Again, not in blood. And this conjugated bilirubin, all of it is gonna get broken down by gut bacteria into urobilinogen. So there is excess urobilinogen in gut. Urobilinogen has two ways to get excreted out. One is through urine, another is through feces. So in urine, urobilinogen is gonna be high. In stool, urobilinogen is gonna be high as well. So you get the concept, right? Excess hemolysis, excess unconjugated bilirubin in the circulation, which gets taken up by the liver. So in the liver cell also excess unconjugated bilirubin. Conjugation in full potential is taking place. Liver is trying its best to conjugate all unconjugated bilirubin. So there is maximum amount of conjugated bilirubin being produced. Since bile flow is normal, so there is maximum amount of conjugated bilirubin in the duodenum. There is maximum amount of urobilinogen within the duodenum, and this urobilinogen has two ways to come out, either through urine or through stool. So there is maximum amount of urobilinogen in urine and maximum amount of stercobilinogen in stool. So that's there. Urine urobilinogen is high. Stool stercobilinogen is high as well. Okay. Now, the presence of bilirubin in urine, is it there or not? See, I've already taught you that bilirubin is of two types: conjugated bilirubin and unconjugated bilirubin. Conjugated bilirubin, which is formed from unconjugated bilirubin within the liver, it is water soluble. Again. There is unconjugated bilirubin, which is produced from the breakdown of hemoglobin, and conjugated bilirubin, which is produced from unconjugated bilirubin by the process of conjugation in the liver. Unconjugated bilirubin, it is lipid soluble, but it is bound to albumin. Conjugated bilirubin, on the other hand, it is water soluble and excretable. Again, unconjugated bilirubin is bound with albumin, so it is large in size, so it can't pass through the filtration membrane of the kidney within the nephron. In between glomerulus and nephron, there is filtration membrane. This large albumin bound unconjugated bilirubin cannot pass through that filtration membrane. So it will not enter the nephron. It will not be there in your urine. It is the conjugated bilirubin, if it is present in blood, since it is first not bound to albumin, and number two, water soluble, it can pass through the filtration membrane and be present in the urine. Got it? So it is conjugated bilirubin. If it is present in blood, it is visible in urine as well, because it is the excretable form. So it is present in urine as well. Now, in prehepatic jaundice or hemolytic jaundice, there is rise in which bilirubin? Unconjugated bilirubin. There is rise in unconjugated bilirubin. And I said that unconjugated bilirubin is bound with albumin, so it can't spill into urine. So there is no bilirubin in urine. Again, if urine has bilirubin, it is conjugated bilirubin, because it is only conjugated bilirubin which is water soluble and an excretable form that can be in urine. Unconjugated bilirubin can't be in urine. So in hemolytic jaundice, there is rise in the level of unconjugated bilirubin in blood, and this unconjugated bilirubin will not enter the nephron, so it can't be in the urine. So urine does not have any bilirubin. Now another concept, when there is bilirubin in urine, the urine becomes cola colored, and this cola colored bilirubin present urine, more specifically cola colored conjugated bilirubin present urine, is referred to as choluria. But in hemolytic jaundice, there is no bilirubin in urine, so there is no cola colored urine, so there is acholuria. Okay. Second, hepatic jaundice or hepatocellular jaundice. The reason behind hepatic jaundice or hepatocellular jaundice is hepatocellular injury. So there is your hepatocyte. This hepatocyte goes through hepatocellular injury. This hepatocellular injury can be due to inflammation, right? Hepatitis or simply cirrhosis. After hepatocellular injury, I've already said two things happen. Number one, there is loss in function of the cell. As a result, conjugation does not take place. Unconjugated bilirubin accumulate. It gets pushed back into the circulation. Number two, there is swelling up of the cell, and the adjacent cell swells up and blocks the biliary canaliculi. It obliterates the biliary canaliculi. As a result, conjugated bilirubin can't escape out of the cell. Accumulation of conjugated bilirubin, it will be pushed back into the circulation as well. So there is total serum bilirubin. There is a rise. Serum unconjugated bilirubin. Also there is the rise. Serum conjugated bilirubin. Also there is rise. As for urobilinogen, the urine urobilinogen remains normal, but the stool urobilinogen, it decreases. Not the urobilinogen, sorry. In stool you have stercobilinogen. Stercobilinogen imparts brown coloration to the stool. Since there is low stercobilinogen in stool, the stool is going to be pale in color. Now, there is a rise in which bilirubin? Both unconjugated and conjugated bilirubin. Unconjugated bilirubin can't get filtered into the nephron. Fine, because it is too large being bound with albumin. But conjugated bilirubin can be. So this conjugated bilirubin does get filtered through the filtration membrane, and conjugated bilirubin gets filtered through the filtration membrane and enters the nephron and is visible within the urine, giving urine cola color, referred to as choluria. So there is choluria. Due to choluria, the urine is brown in color, and due to less stercobilinogen in stool is pale in color. So the patient presents with pale stool and dark urine. Now, these are not the important, they are important, but not the most important tests for hepatocellular injury or hepatocellular jaundice. The most important thing is this. See, within hepatocyte, there are enzymes. And due to hepatocellular injury, the cell is going to be broken. Obviously, the cell is going to be broken. And then there is going to be leakage of whatever enzyme is present inside the cell outside. The enzyme is going to leak outside. After leaking outside, where will the enzyme go? It will enter the blood circulation. So when you perform blood test, you'll find an elevated level of these liver cell specific enzymes. These enzymes present within the hepatocyte enzymes. What are these enzymes? They are AST, aspartate transaminase, and ALT, alanine transaminase. So once there is injury to the cell, they simply leak out of the cell. They leak out of the cell. As a result, there is rise in the level of AST and ALT in blood. AST, ALT level rises. And there is significant rise because all the AST and ALT enzyme present within the cell is going to leak out into the blood circulation. So there is going to be significant rise in AST and ALT. See, I said after hepatocellular injury, two things happen. Number one, loss in function, and number two, swelling of the cell. Due to swelling of the cell, these two are hepatocytes. They swell up due to hepatocellular injury. As a result, in between one hepatocyte and the other hepatocyte, there is bile canaliculi. Due to the swelling of the cell, the bile canaliculi gets compressed. There is compression of the there is compression. See, here is one cell, here is another cell. Let's say there is compression of the bile canaliculi. Then whatever is present within the bile canaliculi will be spilled back into the cell and then back into the circulation. Simple logic. If there is obstruction here, whatever is present within the bile canaliculi can't move forward. It will be spilled back into the cell and back into the circulation. Now within the bile canaliculi, on the wall of the bile canaliculi as well as within the bile canaliculi, there are important enzymes. These enzymes, they are either present on the wall of the bile canaliculi or they are there secreted by the hepatocyte itself. And these are gamma glutamyl transferase and 5-NT. Okay, they are ALP, gamma GT and 5-NT. So there is increased level of ALT, gamma GT and 5-NT as well. But remember, first what is happening? First, there is injury to the cell, and due to injury to the cell, the AST and ALT within the cell leaks out of the cell, resulting in early and significant rise in AST and ALT. Okay, let me write it. So there's going to be early and significant rise in AST and ALT. But after a while, swelling of the cell also results in compression of the bile canaliculi, resulting in late or delayed and minor rise in the biliary canalicular enzyme like ALT, gamma GT and 5-NT. So there is early and significant rise in hepatocytic enzyme, but late and minor rise in the biliary canalicular enzyme in case of hepatic or hepatocellular jaundice. Okay, the final type of jaundice, that is the post-hepatic or obstructive, wait, it's supposed to be in pink, obstructive jaundice. Okay, this is due to obstruction in bile flow. When there is obstruction in bile flow, conjugated bilirubin it doesn't have the way to enter the duodenum. So there is accumulation of conjugated bilirubin within the cell, and it gets spilled back into the circulation, resulting in increased level of conjugated bilirubin in blood circulation. So what happens? Due to obstruction in bile flow, there is obstruction in bile flow. Obstruction in bile flow, also referred to as cholestasis. Cholestasis. It results in total serum bilirubin increases, serum conjugated bilirubin increases, but then the serum unconjugated bilirubin is normal. That's because the process of hemolysis is normal. It's just that there is obstruction in the biliary outflow. So the conjugated bilirubin can't escape into the duodenum. So it is pushed back into circulation. Accumulation of conjugated bilirubin in circulation, increase in conjugated bilirubin in circulation, resulting in conjugated hyperbilirubinemia. Okay, so that's there. Now see, very important point. The fastest way to detect the presence of obstructive jaundice or post-hepatic jaundice or cholestasis in a patient is simply to perform dipstick in the urine of the patient. Dipstick in the urine of the patient. And when you examine the urine of the patient, you will find that there is no urobilinogen in the urine. Why? See, there is obstruction in the bile flow. So the conjugated bilirubin from the hepatocyte will not enter the duodenum. So there is no conjugated bilirubin in duodenum. So there is no urobilinogen in duodenum. So there is no urobilinogen in urine, and there is no stercobilinogen in stool. So there is no urine urobilinogen, and there is no stool stercobilinogen. There is rise in which bilirubin? Rise in conjugated bilirubin. Can conjugated bilirubin get filtered? Yes, it is water soluble. It is an excretable pulp. It can get filtered into the nephron. So it is present in the urine, and the presence of bilirubin or conjugated bilirubin, to be more specific, in urine is referred to as choluria, which gives urine its cola color. In this case, the presence of pale stool due to absence of stercobilinogen and dark urine due to presence of bilirubin in urine is even more appreciable. So there is pale stool with dark urine, highly appreciable in post-hepatic jaundice. In hepatic jaundice, there is low level of stercobilinogen. So the stool is not completely pale. But in post-hepatic, there is absolutely no stercobilinogen. So the stool is very pale and the urine is dark due to conjugated bilirubin. Okay. See, since there is obstruction in the bile flow, what is going to happen? The biliary enzymes that are either stuck on the wall of the bile canalicula or present within the biliary duct system will get acted upon by the bile salts, right? Because there is accumulation of bile salt, there is accumulation of bile here, the bile is unable to go forward. So this bile accumulated here is going to act on these enzymes present on the wall or within the lumen. They are gonna act, and then they are gonna break it off the wall, and it's gonna enter the cell and then into the blood circulation, resulting in increase in their level. What are they? They are the ALP, alkaline phosphatase, gamma GT, and 5-NT. So there is increase in their level, increase in their level due to biliary. Eventually, since bile salts are getting pushed into the cell, the bile salt is obviously toxic to the cell. It is going to harm the cell, and the cell is going to get damaged as well. So the enzymes present within the cell is going to come out later. eventually, what is present within the hepatocyte? AST and ALT. So they will leak out. They will leak out after damage to the cell. So there is going to be rise in AST and ALT, but then the rise is not significant and occurs later. So again, so first early and significant rise, early and significant rise is that of biliary canalicular enzyme, but late, delayed and minor rise is that of hepatocytic enzyme in case of post-hepatic or obstructive jaundice. When there is obstruction, it's not just the conjugated bilirubin that is being obstructed, right? It is the bile salt that is being obstructed. It is the cholesterol that is being obstructed. So conjugated bilirubin is pushed back to circulation, resulting in conjugated hyperbilirubinemia. But at the same time, bile salt and cholesterol is also being pushed back to circulation. So there is bile salt in blood circulation, cholesterol in blood circulation. Bile salt, when they reach the skin, they cause frequent itching, and this is referred to as pruritus. So due to bile salt, there is pruritus. And as for cholesterol, they will go and deposit underneath the skin, resulting in xanthoma. So the patient presents with pruritus and xanthoma due to the presence of bile salt and cholesterol in blood circulation. Yep, that's it. Obviously, we are going to revise all of that at the end. Okay, so I want you to answer them, even though I can't hear you, but then match the answer with this, what I'm going to write right now. So there's pre-hepatic, hepatic and post-hepatic jaundice. Again, the same thing. First, total bilirubin, then unconjugated bilirubin, then conjugated bilirubin, then Vandenberg reaction. Then we are going to shift to urine and stool. Urobilinogen in urine or urine urobilin, stercobilinogen in stool or stool stercobilin, and then presence of bilirubin in urine, which is urine bilirubin. Then the presence of bile salt in urine or urine bile salt. Then within the hepatocyte, you have AST-ALT that leaks out into blood circulation. So you are going to see AST-ALT, the hepatocytic enzymes. Then within the bile canaliculi, you have ALP, gamma GT, and 5-NT, the presence of those in the blood. And then the other lab diagnosis that you can do, or other diagnosis that is appreciated as well. Okay, first, serum total bilirubin. All three is a case of jaundice, and jaundice has hyperbilirubinemia. So serum total bilirubin is a reason in all three jaundice. In pre-hepatic jaundice, there is excess hemolysis resulting in excess or elevated unconjugated bilirubin, resulting in unconjugated hyperbilirubinemia. So unconjugated bilirubin is a reason in pre-hepatic jaundice. In hepatic jaundice, due to hepatitis or hepatocellular injuries, there is loss of function of the cell, so conjugation does not take place. Unconjugated bilirubin is a reason. In post-hepatic jaundice, it's normal. Pre-hepatic jaundice, conjugated bilirubin is normal. In hepatic jaundice, due to inflammation or swelling of the cell, they compress on one another, obliterating the bile canaliculi space. As a result, whatever conjugated bilirubin is present within the hepatocyte won't come into the bile canaliculi because there is no bile canaliculi. It has been compressed. The conjugated bilirubin is pushed back into circulation. So there is elevated level of conjugated bilirubin in hepatic jaundice as well. In post-hepatic jaundice, due to obstruction to bile flow or cholestasis, there is conjugated hyperbilirubinemia. Vandenberg reaction. Short, what is Vandenberg reaction? Vandenberg reaction is a biochemical test that is used to detect bilirubin. Not just bilirubin, detect bilirubin, but to distinguish the type of bilirubin in blood serum. See, if within blood serum there is conjugated bilirubin, then when you put a Vandenberg reagent in it, it shows coloration. Since the reaction is direct, there is direct reaction. Since conjugated bilirubin shows direct reaction with Vandenberg reagent, it is also referred to as direct bilirubin. if there is unconjugated bilirubin in serum, after you put Vandenberg reagent, color is not seen. But then after you put another reagent like alcohol, color is seen. Now since there is indirect reaction, the unconjugated bilirubin is also referred to as indirect bilirubin. When there is both conjugated bilirubin and unconjugated bilirubin, upon addition of Vandenberg reagent, due to the presence of conjugated bilirubin, coloration is seen. But upon addition of alcohol again, due to the presence of unconjugated bilirubin, the color becomes even darker. Since the reaction is taking place in two phases, we refer to this as biphasic reaction. Okay. So in prehepatic jaundice, there is unconjugated bilirubin which gives indirect reaction. In hepatic jaundice, there is both conjugated and unconjugated bilirubin, so it gives both reactions, so biphasic reaction. In post-hepatic jaundice, there is just conjugated bilirubin which gives reaction directly, so there is direct reaction. Okay, now urine urobilin. In prehepatic jaundice, urine urobilin is increased, stool stercobilin is increased. In hepatic jaundice, urine urobilin is normal, stool stercobilin is low. In post-hepatic jaundice, due to obstruction to bile flow, nothing enters the duodenum. So there is no conjugated bilirubin in the duodenum, there is no urobilinogen in duodenum, so there is no urine urobilin, there is no stool stercobilin. Okay, now urine bilirubin. In prehepatic jaundice, unconjugated bilirubin has risen, and unconjugated bilirubin is bound to albumin. It is not excreted into the nephron. So there is no urine bilirubin detected, which is referred to as acholuria. In hepatic jaundice, there is conjugated bilirubin. It can enter the urine. So there is choluria. In post-hepatic, there is conjugated hyperbilirubinemia. Conjugated can enter the urine. So choluria. Urine bile salts. In prehepatic jaundice, there is urine bile salt. In prehepatic jaundice, there is absent of urine bile salt. Wait, let me just give a cross. There is no urine bile salt. Because, see, in prehepatic jaundice, the bile flow is normal. So the bile, it can enter the duodenum. So if bile does not come, the bile salt does not enter the blood circulation, it does not go to the kidney. So there is no bile salt in the kidney. So there is no bile salt in the urine. Similarly in hepatic as well, it can be slight amount of urine bile salt. Why? Because in hepatic jaundice, along with loss of function of the cell, there is also swelling of the cell, resulting in compression of the bile canaliculi. So there is certain level of obstruction taking place. When there is obstruction taking place, the bile salt will not enter the duodenum. It will be pushed back into the circulation. From the circulation, it can reach the kidney. From the kidney into the nephron. So slight level of bile salt is seen. But in post-hepatic jaundice, there is full-blown obstruction, complete obstruction. So all of the bile salt gets pushed back into the circulation, enters the kidney, and then is found in the urine. So there is elevated urine bile salt. AST, ALT. Okay. Prehepatic, there is no AST, ALT level is normal. ALP gamma GT level 5 is also normal. We need to distinguish between hepatic and post-hepatic jaundice. In hepatic jaundice, since first there is hepatocellular damage, there is leakage of AST, ALT. So there is fast and significant rise in AST, ALT. But later on, due to swelling of the two cell, compression of the bile canaliculi, blockage of the bile canaliculi, presence of the bile canaliculi enzymes, it gets pushed back into the cell and into the circulation. So delayed and minor rise takes place. As for post-hepatic jaundice, due to obstruction to the bile flow, due to cholestasis, there is significant and early rise in ALP, gamma GT, 5-NT, or basically bile canalicular enzymes. But later on, the bile salt that gets regurgitated back, will damage the cell as well, and the AST, ALT leaks out. So there is delayed but slight rise in AST, ALT. As for other, in prehepatic jaundice, there is excess hemolysis taking place. And hemolysis can either be intravascular hemolysis or extravascular hemolysis. And the biochemical features of both intravascular and extravascular hemolysis I have taught in detail under hemolytic anemia under my one short video of anemia. Hepatic jaundice, since there is loss of function of the cell, the prothrombin time increases as well. If it is acute, just the prothrombin time increases, but if it is chronic injury to the cell, then albumin level in the blood decreases as well because the liver cell stops making albumin. As for post-hepatic, there is cholestasis. Due to cholestasis, the conjugated bilirubin is pushed back into the circulation. But at the same time, bile salt and cholesterol is also pushed back into circulation. Due to bile salt, there is pruritus, and due to cholesterol, there is xanthoma. That's it.